Hey, what's up guys? It's Dr. McDaniel. I'm here at Plastic Surgery and I wanted to answer some questions that we've gotten about different surgeries that I do and most of the surgeons here do. The first question is about breast augmentations. And it asks, how do I decide what size breast implants to place? And that really depends on what your goals are as the patient, is also what your body can accommodate. So, I usually view a cup size between 150 to 200 cc's, whether it's silicone or saline. Now, that is going to help me when I decide, someone who says I want to be a D and I'm currently an A or I'm currently a B. I can use a little bit of a quick math to figure out what rough size implant you need and go from there to decide what will fit within your body. Depending on the body, it depends how wide the breast is as to how wide of an implant or what diameter implant it can really accommodate, as well as how thin your skin is. That dictates whether or not you might need a lift as well as where the areola is positioned. Another question is, what is the difference between silicone and saline? So silicone implants and saline implants are both safe. We use both daily, and also depends on the patient's body and what they're comfortable with. So silicone implants are made of a cohesive gel. So if you cut them in half, they'll stay. Think about it like a gummy bear. And in fact, that's where that kind of term comes from, gummy bear implants. And then a saline is a silicone shell that is filled with saline to a certain volume. If that's cut in half, obviously it will deflate and your body will just absorb that water and you'll pee it out over time. Both of them, though, will leave something in your body if it were to rupture. So if you have an implant rupture, you need to have that treated, regardless if it's silicone or saline. The difference, in my opinion, is that silicone has a little bit more natural feel, and that comes into play if you have a lot of breast tissue. So if you have very little breast tissue and I'm placing a saline implant, you may see a little bit of rippling on the sides, depending on if it's placed under the muscle. Whereas saline, it's going to be more of a smooth edge because of that cohesive gel. It maintains its structure a little bit better than the saline. When you feel it, silicone, like I said, feels a little bit more natural. So if you don't have much breast tissue, you're going to want maybe to consider a silicone so you'll have a more natural feel. Whereas if you have a lot of breast tissue, you're going to feel your own breast tissue regardless. So silicone or saline are both fine to use in your case, and either one will work well, especially for the look and then the feel in that situation. Some differences between a breast lift and a breast reduction. And I think this is important because a lot of patients think that a breast lift is a breast reduction and vice versa, and they're different surgeries completely. So I tell patients, try to think of a breast lift as removing skin and repositioning the areola to improve the shape and kind of silhouette of the breast. It's not going to help a lot with volume. It's going to really reposition the areola to give you a more perky look to where the nipples are positioned. Now, a breast reduction, on the other hand, is where you have really too much breast tissue. You have back pain, you have bra strap grooving. A lot of women will actually develop fungal irritation and kind of some rashes under their breasts from heat and the weight of them. And so in those situations, the goal of surgery is not just for cosmetic purposes. We're not just repositioning or removing skin and repositioning the areola. In this instance, we're actually removing breast gland tissue to relieve some of those symptoms that the patients are having. So a patient who is getting a breast reduction, blood flow to the areola is very important because what we're doing is removing part of the breast tissue, which to some degree provides that blood flow to the areola. Now, depending on what doctor you go to, there are different pedicles or blood supplies to the areola they use. And so if you're doing something like smoking or you have nicotine in your system, that is going to make your blood vessels constrict. It's going to limit the blood flow to the areola, and it can really affect the health and long-term survival of the areola. So those are things you definitely need to let your doctor know. But the difference, again, between lifts, reductions, is that a lift is more for cosmetic purposes. Reduction is more for functional purposes. You do lift the areola with the reduction, but you're not removing breast tissue with a breast lift. So a little bit of differences and a little bit of nuance in that. Some patients may need, if they want implants, it sounds kind of counterproductive, but some people may need implants with a breast reduction because the volume and where their breast tissue is located has dropped down and it's below and in kind of what's called a bottomed out position of the breast tissue. In that instance, we may elect to remove some breast tissue do a lift at the same time as that reduction, and then put implants underneath, small implants, just to give you more volume in the superior pole. And that's going to help give you a better shape overall, as well as a little bit improvement in symptoms, because you will be a little smaller if we're removing a significant amount of breast tissue, but you're going to have a better shape as well. So kind of a unique circumstance for some and very few people who need all of those things achieved in their surgery. One misconception, a lot of people say, I want implants or I want to lift so I don't have to wear a bra anymore. That's very important to think about after surgery, because gravity is still going to play a part of your breast. They're still going to fall with gravity over time. So everyone who has implants and a lift, I recommend wearing a bra for the rest of your life. Recommend sleeping in one, recommend wearing one during the day. Now, obviously, if you go one night, one event where you have an outfit that doesn't support wearing a bra, or you don't want to wear one, that's not what I'm talking about. I'm talking about your routine should involve support for your breast tissue to really help it from falling faster. Think about when you have implants, you're going to have more weight on your chest. That's going to drop faster than not having them. So it's more important to wear a bra with implants than without, so you don't need a lift as soon after your implants. Some questions here about changing the shape of your areola after breast lift or breast reduction. So in most circumstances, the areola is going to be downsized. Usually if someone needs a lift or reduction, the areola has been stretched, whether that's from weight gain or breast gland hypertrophy or growth when you have children and you breastfeed. So we typically downsize that. I downsize to about a 40 to a 42 millimeter diameter. So if you measure your areola and you're larger than that, you'll most likely get a reduction. And that's going to also be a round circle, just like the shape that your areola are, but they're going to be the same size in diameter, and then they're going to be positioned in the same location as well. What are some approaches to breast augmentation? So there are a couple different ones, and there's not a right one. Surgeons have better results with different approaches. Probably my favorite is the inframammary fold, or underneath the breast in the crease here. I think that's really easy access to get to your muscle. Again, I place most of my implants under the muscle, and I can get to that easily, and that incision hides well in the crease once the breast implant is there and it falls on top of it. Now you can also do it around the areola, called a peri-areolar incision. And that is another good option for someone who doesn't want scars on their skin, because you can actually hide it pretty well between the pigmented skin of the areola and your skin around the areola. It kind of has a demarcated region there that can hide an incision well. I typically don't like to do that for someone who is younger and may want to have children in the future. It can impact some of the ducts that contribute to breastfeeding, and so I recommend doing it under the fold for those individuals. Now, there are other surgeons who do other approaches. Some go through the armpit or transaxillary. Some go through the belly button, transumbilical. Those are good options in other people's hands. I don't do a lot of those, but that doesn't mean they're not good surgeries and good options if those surgeons do those well. So again, just have a conversation with your surgeon and ask what they recommend for you and your situation. What are some risks of breast surgery? So with implants, the main risk that I worry about acutely is bleeding. However, long term, you can develop what's called capsular contracture. So what that is whenever you place an implant in your body, you're going to form a capsule around it. It's basically a scar around the implant. That happens with breast implants, with facial implants, with butt implants, all of them, because it's our body's reaction to wall off that foreign body or the implant. So occasionally that scar tissue will develop some muscle fibers in it that actually cause the scar to shrink over time and contract, hence capsular contracture. There's different stages of this, and it's a progression that will eventually, if it reaches stage 4, lead to displacement, hardness of the implant, as well as pain of the implant. So you'll have a lot of asymmetry. It's a little ironic, but a lot of patients like the side that's contracted because it lifts the implant up higher, so you have more perkiness. But that's not a very natural look, and it's not the goal of the surgery. So when they come in, a lot of times I have to redirect, say, no, this is the non-capsulated implant. We need to try to match that side, not the capsulated side. What happens if after surgery I want to change the size or type of my implant in the future? So I tell patients, wait until you're fully healed to really decide on what surgery or what size implant you have and how it's affected your body. So initially you're going to have a lot of swelling, you're going to look probably bigger, and they're going to be high if they're placed under the muscle. As they settle and your swelling goes away, you'll see your results. They're going to be more natural and fit your frame better. If, however, you do decide you want to do a different kind, saline versus silicone or vice versa, or a bigger size, I like patients to wait about 6 to 8 months to do that. And it's actually a lot easier surgery to do after you already have the implants placed, because all we're going to do is go into the same capsule. We don't have to release muscle if we're going under the muscle, and basically go into the same capsule. And depending on how big you are, we may need to alter that capsule to allow it to expand like an accordion to house a larger implant. So we have some implants here. I'll show you those. These are 2 silicone implants. These are 365 cc. They're both 365 cc implants, and these are higher profile. So that's another topic. These are gel, cohesive gel. So again, like I said before, if I cut this in half, the half that I'm holding is going to stay there. It's not going to flow out. And that's how silicone implants used to be back in the 90s. And they caused a lot of problems, because if that happened and the silicone came out into your tissue, your body had an immune response, get very inflamed, and attacked that silicone and caused a really thick scar tissue in your breast. So thankfully, these don't cause those effects if they were to rupture. Now, the difference in profile, there's a lot of people say I have high profile, really perky implants. And the only thing about the profile is just the width and projection of the implant. So this is a high profile silicone implant. If I had the same volume, a moderate profile, it would have a little bit less projection and be a little bit wider. And why is that important? Because you can achieve perkiness with both implants, moderate and high profile. But someone who has really broad chest and broad base of their breast tissue are going to need a broader implant, because if you have a narrow implant and your breast is wider, it's not going to fill your tissue and it's not going to look natural. It's going to be very narrow and kind of come into and off the chest wall slightly, and it doesn't look very, very natural. So that's why it's important to really get fitted for your implants and make a decision with your surgeons. You know, there are plenty of people who come in and say, I want this or I want that, and if I can safely and predictably achieve that, I'm happy to do it. So a question I get frequently is the difference in profiles of implants. There's high, there's moderate, there's low, there's extra high, and depending on the company, different companies call it high or full. Those are the same thing. However, the difference between a moderate and a full profile implant is the width of the implant and the projection. So the higher the profile, the more projection you're going to get, and the less wide the base of the implant will be. So it'll be narrower. If someone comes in and they have a wide breast base or chest wall, they need broader implants. So they may need a moderate profile implant to fit their tissue better. If you get too wide of an implant, it's going to hang out laterally and go into your armpit a little bit more. And if it's too narrow, it's not going to fit your frame and look very natural. So you really need one that fits your frame regardless of the profile. Now there's a little bit of flexibility in that if you want a certain size implant, you may just need to have a wider base. So again, that may come back and go into a moderate versus high profile depending on what your measurements are when we do that at your pre-op consultation. And I think one thing to take away from that is neither you or your surgeon should independently be making a decision on your breast implant size. It needs to be a conversation, a discussion of the pros and cons of each decision you make, and then you come together to agree on what you want to achieve your goals safely and predictably in the surgeon's hands. Can patients resume regular activities and exercises after breast surgery? So it's a really good question, and it's important. The topic I mentioned earlier is capsular contracture. That can increase the risk of that if you start working out, especially your pectoralis muscle, too soon after surgery. If you think about it, the implant, like I said, is forming scar tissue around it or your capsule. If the implant is constantly being moved and irritated by that muscle, it's going to cause more inflammation, and that scar tissue is going to be thicker and stronger and potentially encapsulate or contract to cause that capsular contracture. So I like patients to wait usually 2 to 3 months after surgery to do chest exercises, meaning pushing, pulling, lifting. However, low impact exercises, cardiovascular, with good support, you can start doing that around 6 weeks or so. Okay, you want to really give your body time to heal, but then you can get back into your healthy and active lifestyle. What signs should I look for after breast surgery that may be a complication? So again, any surgery has complications, okay? The most common complications acutely are usually bruising, bleeding, you're gonna have swelling, you're gonna have discomfort. Acute bleeding, or what we call a hematoma, is something that may require additional surgery immediately if it's expanding, okay? If it's a small hematoma that is just causing some bruising, that's a different story, but that's something to look for immediately after surgery. If one breast is significantly bigger than the other breast, especially if it was similar right after surgery and then you look, later that day and it's all of a sudden a lot bigger, that's something you need to let your surgeon know about immediately, because that's not something you wait over the weekend to figure out on Monday, okay? Long-term complications of breast augmentations, at least, are one, the capsular contracture that I've mentioned before, and two, something called flexion distortion. And that is whenever a patient has an implant placed under the muscle is going to be released off of the ribs and the sternum. Those muscle fibers will sometimes lift the skin and the implants up. And you can tell if someone has implants under the muscle by having them pushed together like this. The implants and the tissue will contract laterally along the parallel fibers of the muscle here. And sometimes whenever people raise their arm or lift or move that muscle, it can pull the skin a little bit, and that's called flexion distortion. That's something that most implants will have some degree of after a submuscular placement. But if it's really asymmetric and one's really pulling, that's something that can be treated, and something that should be treated to improve that symmetry, release some of those fibers, and really make it more symmetric in your daily motions. Can breast surgeries be done in combination with tummy tucks or liposuction? Absolutely. My favorite surgery is a mommy makeover, so that I consider either a tummy tuck or liposuction with breast surgery, whether it's a lift and implant or just an implant or just a lift. Those are some of my favorite surgeries because it's someone who has either lost a lot of weight, worked really hard to lose that weight, and now we are going to restore their body to what they've been working towards. They've done the hard part, the weight loss, and we're just giving them the result, which is their body back. Other people who deserve a mommy or can have a really nice change with a mommy makeover are moms, right? A mom puts their body through hell to really give birth. The breast, the stomach, the skin gets damaged. You have weight that you didn't have before. It's harder to lose. And you have muscle separation in your stomach. Those are things that aren't going to get better with time. The skin's not going to all of a sudden immediately shrink back. If you have stretch marks, those are going to be there. And the only way to treat those are to remove them with a tummy tuck. Muscle separation, you can improve the tone of the muscle, but the fusion in the midline here, or the linea alba, is not going to return unless that is repaired surgically. Again, like I said, there are exercises you can do to strengthen those muscles, but there's still separation regardless. So you can tell if you have that by doing a sit-up, and you can see bulging in your stomach. For moms out there who may want to see, do I need a tummy tuck? Can I just do liposuction? That's something to really evaluate if you have what's called diastasis recti, or separation of your muscle. So again, just to recap, if you have stretch marks and skin that is loose and hanging a little bit, and you have separation of your muscle, those are things that won't be repaired by doing exercises or going to the gym. No amount of workouts will improve your skin or that muscle separation specifically. So a consultation will really help you figure out if that's an option for you and what the best treatment for you is, whether it's liposuction, tummy tuck, breast lift, breast augmentation, or both together. What kind of scarring can I expect from a breast lift? And it's a good question, because if you're having a breast lift, you're going to have scars. Now, I tell everyone says I want a really thin, narrow, flat scar, and I want that for every patient too. When you get out of surgery, you're going to have a thin line that is sutured the same way I suture everyone. I tell people a scar is really dictated by two things. One, how much you're going to care for it and what you're going to do to protect it and maintain it and maximize the cosmetic result. And two, a genetic component. Some patients are predisposed to keloids. They're going to have thick, raised, big scars, and that's not something that can really be changed. It's going to happen regardless. What can be done about that situation is that if you feel like you're getting a keloid, or if you know you get keloids and you're watching and see it starting to form, early injection of steroids can really help minimize the amount of scar tissue that forms. It blocks that production of that collagen that leads to scarring in the implant or in the scar itself. So back to breast lifts though. Most women will have an anchor breast lift if they're having a breast lift. That means you have an incision around the areola where it's been downsized, like I mentioned before. You'll have a vertical component that's going to be able to bring the breast tissue together. And then you're going to have a inferior or anchor component that allows us to remove the excess skin vertically. When that comes together, it forms the anchor scar that most people think of. Now, if you don't have a lot of drooping and you only need to raise the areola a couple centimeters and you may only need to remove a little bit of skin, sometimes you can get away with what's called a lollipop lift or a vertical mastopexy. That means you just have the vertical scar and not the anchor. that really is for very few patients who have a very small amount of ptosis or drooping and just need a little lift to help restore the volume that they have.